For many parents, managing a teen's ADHD feels like a constant uphill battle, even with therapy and medication. But the standard approach is failing. Over half of teens stop their ADHD medication within just 1 year. This isn't defiance. It's because their support system is fundamentally mismatched for their needs. A 50-minute weekly session is a drop in the bucket against the 167 hours they spend in their real world. We'll show why standard therapy fails teens with ADHD and how a more intensive model is designed for success. Standard therapy is disconnected. They learn a skill in an office, then return to the same family dynamics and peer pressures. The timing is wrong. ADHD requires intervention at the point of performance, not days after a meltdown. Engagement is often superficial. Teens can give surface-level compliance, nodding along without real buy-in. So we have a model that's disconnected in place, in time, and often in emotional depth. Is it any wonder it's not enough? But what's happening inside the teen brain that makes these methods so ineffective? The answer is the prefrontal cortex. The prefrontal cortex is the brain's CEO. It manages impulse control and emotional regulation. In all teens, it's under construction. This makes it neurologically difficult to take a concept learned on Tuesday and apply it during a moment of crisis on Friday. While physical hyperactivity might decrease, the challenges with executive functions like time management and emotional control get worse. This developmental gap creates the perfect storm for another, often overlooked problem: co-occurring conditions. ADHD rarely travels alone. Anxiety, depression, or substance use are often intertwined with it, not separate issues. A weekly therapist plays whack-a-mole, shifting focus between panic attacks, failing grades, or social fights. This is a key reason so many teens stop their medication. Pills may improve focus, but they don't teach how to cope with anxiety. If the standard model is broken for complex cases, what does a better one look like? This is where IOPs come in. The first difference is intensity. Instead of 1 hour a week, IOPs involve therapy several hours a day, multiple days a week. This intensity directly addresses the prefrontal cortex problem, providing constant reinforcement to build new neural pathways. Critically, teens in IOPs still live at home and attend school. They test drive new skills in the real world every single day. But it's more than just hours. It's what happens in those hours. IOPs use an all-encompassing method for the teen's challenges. Remember the disconnected environment? IOPs make family therapy a core component, giving parents tools to build support at home. Teens join group therapy with peers facing the same struggles. This reduces isolation and creates a space for shared learning. Therapy is an active workshop for life skills. Sessions are dedicated to practicing time management and emotional regulation. And the whack-a-mole problem with co-occurring conditions? IOPs have an integrated team treating the whole person, not just a symptom. So you have intensity for the brain, family involvement for the environment, and an integrated team for complexity. A system to match the problem. This doesn't mean standard therapy is useless. But for complex ADHD, it is like bringing a screwdriver to a job that needs a full toolkit. The goal of an IOP is not just crisis management. It is to build lasting skills, fostering resilience and self-confidence for the long term. Intensive outpatient programs succeed because they are built for the neurological and emotional complexity of adolescent ADHD. If you feel stuck, know that more effective options are available. Look for IOPs in your area that specialize in adolescent mental health. Talk to your teen's doctor or a school counselor about whether an IOP could be the right fit. Do not be afraid to seek a higher level of care. Your teen isn't failing therapy. The therapy may be failing your teen. Finding the right support can make all the difference.